Everyone, sorry about Monday. I hope you all got notification or checked your WebCT before coming over to the classroom. We'll stay on schedule for today and begin with lecture 18. Continuing our discussion of the pharyngeal apparatus. So this is pharyngeal apparatus 3. We all know that the change from segmental development to non-segmental development is most pronounced, certainly at the rostral end or the cranial end. Yes, question? Certainly. It'll be the same amount. I'll probably give 5-6 days. It'll stay at 2 attempts. Yeah. Okay. You're welcome. As I was saying, the cranial end of the developing embryo undergoes probably the most tremendous changes. Even though there's some representation of segmental origin, we know that there's a tremendous difference. The development of the central nervous system, the forebrain, certainly changes things significantly. The branchial or pharyngeal arches still have a segmental type of an appearance, although they are developing through highly specialized migration of the specialized mesenchymal cells originating from the neural crest and undergoing the surface ectoderm and creating those bulges, grooves, and then internally the endoderm lining the inside of the bulges and grooves called pouches. So in the 2 previous lectures, we followed the development of those areas. We'll obviously see them again when we talk about the development of the nervous system and the vascular system. So today our focus is primarily on the development of the palate. And we see on the right-hand side of this image a view of the young adult hard palate at the base of the skull, a view from the base of the skull. We, of course, recognize the teeth, the incisors at the frontmost portion. And between the left and the right incisors, there is a foramen, the incisive foramen. So this already makes us think, along with looking at the premaxillary part of the maxilla, shown here, that there's some type of ingrowth into this area surrounding some structure, leaving the incisive foramen. We also see the 2 horizontal plates. There's sutures shown here in the midline, and the sutures between the other parts of the hard palate. So this makes us think that something might be invading from the 2 lateral sides, and of course that is the case. And then the palatine bone, very complex bone, most dorsally, if we want to think of it that way, or at the backmost part of the hard palate, forming the final part. And we all know that the soft palate extends from this palatine bone with the uvula in the center. So these are the bony structures that will be developing from the mesenchyme within these folds that are going to develop and push into this area to separate the oral from the nasal cavity. So if we take a look at this mid-sagittal view, this very limited sketch of the 20-week fetus, we recognize in the nasal cavity the nasal concha are beginning to form. Some portions of the palate, the hard palate, are there already. We see an incisor tooth in the upper jaw, the maxilla, and of course the mandible bone is developing inferiorly to contribute to the formation of the floor of the mouth, which is occupied primarily, as we know, by the tongue. And we recall that basically at the junction with the soft palate, we saw the hard palate joining the palatine bone over here. This basically represents the junction of endoderm of the foregut and the ectoderm of the forming oral membrane by the branchial arches and the maxillary arch coming in to form in the anterior midline. It's all covered by fleshy mucosal membrane, as we know, glands, epithelium, connective tissue, vasculature, and rich neural supply. So this represented then the site of attachment of the buccopharyngeal membrane, or the oropharyngeal membrane, that we identified way back when we were talking about the prechordal plate, or prochordal plate. Thus, the primary palate will form relatively early. There will be a median palatine process, so we predicted that there's going to be processes or protuberances developing. Here's one in the midline that will develop between the maxilla, the right and the left maxilla. Remember, these are paired bones where we have the bilateral symmetry. So this will begin in week 6, and then it becomes a minor component of the adult hard palate as the head grows and develops. So we'll see images where the tongue is occupying most of the oral cavity and even pushing up into the primordial nasal cavity. And later, as the head and face begin to develop and elongate, the tongue will be lower and the nasal cavity will be formed when the hard palate closes off the two cavities, the oral and the nasal cavity. So this figure 1013 lets us take another look at the lateral view where the median palatine process is originating, and we recognize the tongue. We see that the nasal cavity and the oral cavity are continuous. If we make a plane of section, a coronal plane of section, at this level indicated by the dashed line, we'll see them in C, E, and G. And in C, E, and G, we'll look at different stages of the development from the 6th to the 12th week. So in panel B, we're looking at an inferior view of the roof of the oral cavity and into the nasal cavity as well. And we see some unique structures developing. The median palatine process is our focus for the moment. We see that far dorsally, remember we're looking from below, so when we're looking up, that's dorsal in the head. And the nasal septum is beginning to develop up there and will descend down. So there is actually a space between this median palatine process extending up between the nasal septum and that process. We see the lateral palatine processes are beginning to form on each side of the forming maxilla from that maxillary eminence. And again, this would be lined with ectodermal epithelium of ectodermal origin, and underneath will be the invading mesenchymal cells that are pushing into this area, continuing to divide and extending these processes. So we're obviously going to follow these structures all as they continue to move toward a common point at the raphe, the palatine process raphe, that midline junction, the nasal septum up above. We're also recognizing the labiogingival membrane close to the junction of the oral cavity and the labia or the lips, and there is a bulge here, of course, that represents the developing gum. So we are always thinking about underlying mesenchyme and what it's beginning to develop into. All the connective tissue, which includes the blood, of course, let's eliminate blood at this point. By this point, blood is being formed in other locations, but still of mesenchymal or mesodermal origin. But the skeletal system, all the connective tissue cells like fibroblasts and the extracellular matrix that's being secreted by those cells, and the vasculature itself. And of course, the primordium of the teeth are going to begin to establish themselves in this area ultimately as well. So now when we look at panel C, again, it's a coronal view, and we're looking from the front. First, we orient to the brain. That would be dorsal. So we see that the olfactory nerves had established their connection into the primordium of the nasal mucosa, the olfactory mucosa, excuse me, specialized portion of the nasal mucosa. The nasal septum is beginning to develop. We saw that from the dorsal view. So if we quickly just go over to panel D and look up, what we would be seeing there between the two extending lateral palatine processes, the nasal septum would be up there growing down in the midline. We recognize also the primordium, the development of the eye in this area. So the face is still very early in its development. The darker red, of course, is representing early evidence of bone formation, and it's not really bone yet, we know that. Just starting to, the mesenchymal cells are just starting to differentiate into the bone-forming cells, the osteoblasts. We see also, first, I guess, orient to the tongue, protruding dorsally in this area, and separating the early lateral palatine processes on each side. As the head and face continues to grow and elongate, the tongue will have a relative drop, and these processes will be able to extend dorsal to the tongue. So the growth of the lateral palatine processes is shown here in panel D. We see the remnant of the median palatine process. Remember, these were part of the maxilla in the adult bone that we saw before, and the incisive foramen will persist in here. The two lateral palatine processes are migrating directly toward the midline and also extending at their posterior-most margin more posteriorly, and ultimately will meet up with the developing palatine bone that we saw in the panel B of this figure. So that was a series from the 6th to the 12th week. So there's a lot that is occurring over that time period to complete the formation of the face, oral, and nasal cavities. And of course, it does continue from there to the point of making the secondary palate. So this will be the primordium, both the hard and the soft palate of the adult, and it's formed predominantly by the lateral palatine processes that are originating from the maxillary prominences. Remember, the maxillary prominence was not one of the pharyngeal arches. It was a unique structure above the first pharyngeal arch, the mandibular arch. And it starts as projections lateral to the tongue, and eventually, as we said, will be able to fuse in the midline dorsal to the tongue. Here then we are continuing on in the weeks, so we hadn't reached the 12th week in the previous series. We're closer to the 12th week here. We orient to the nasal septum, just inferior to the forebrain up here. We see the olfactory nerves, the eyes are developing more, and we see the nasal septum and the lateral palatine processes. So by this stage, the tongue and oral cavity have elongated enough to create some additional space for these lateral palatine processes to approach each other in the midline. We note the darker red color reminding us of early bone development, mesenchymal cell differentiation into the early osteoblasts that will lay down the bone. Obviously, we'll talk about the development of the skeletal system separately later on when we continue with the organogenesis studies in the class. So back to the nasal cavity, we note that the nasal concha are also beginning to develop. So these are these protuberances, and we know they end up being curled and curved in their shape, and there's some evidence of that already, and they are present on the lateral walls of the nasal cavity. So the nasal septum is going to form the medial wall of the nasal cavity, and the maxilla with the concha will form the lateral walls. And obviously the olfactory epithelium will be in the roof, and then the hard palate formed by the lateral palatine processes will be the floor of the nasal cavity. Roof of the oral, floor of the nasal. Kind of a little apartment arrangement there. So here in panel F, we are looking at, again, an inferior view of the roof of the oral cavity. And we can call it the roof now in that the lateral palatine processes have nearly completed their fusion with the primary palate, that median palatine process, now taking on a new name. And this fusion starts anteriorly at the front part of the oral cavity with the junction of the primary palate, and will be like a zipper basically moving toward the back of the roof of the oral cavity. I guess I should be saying posterior most, I think I've been saying dorsal, but the posterior most portion of the lateral palatine processes are continuing to extend until ultimately they'll reach the early palatine bone and contribute, of course, along with that developing structure to form the last part of the hard palate and the fleshy covering, the endodermal lining, and the underlying mesenchymal cells contributing to the skeletal muscles in this area, the vasculature, connective tissue, and of course the endodermal derivatives as well. Thus we can proceed to an actual histological section, figure 1035. So this is a frontal or coronal section. It's through the developing mouth and the nasal cavity at about a 22 millimeter human embryo. So this is at about 54 days. Thus, we don't have the brain to orient to, but the nasal septum is prominent in this section. And of course, since it's labeled, it helps us to recognize things. We note that the concha are not yet recognizable in the lateral walls of the early nasal cavity. We see the core of the nasal septum looking almost like cartilage already. So we know that the bony nasal septum or the cartilaginous portion of the nasal septum will develop from this part, and the lamina propria, underlying connective tissue of the mucosa, will develop in this area. So at the dorsal-most aspect of this, going all the way up to the top of the head, posterior that way, dorsal that way, when you get to the head, would be where we'd find the roof of the nasal cavity, and we know that the olfactory epithelium would be there, and this is where we saw in the illustrations the olfactory nerves already embedded within this specialized sensory structure. There's some other structures identified here: a vomeronasal nerve, vomeronasal organ, and vomeral nasal cartilage. So there are other structures. We're not going to really bother with those at this stage of our studies, but it does remind us that the neural innervation, I have that on the nerve, yeah, vomeronasal nerve. The neural innervation was established very early on, so the sensory fibers and motor fibers coming into these areas migrated into there very early from the neural crest cells or extensions from the cranial, the brainstem for the cranial nerves, spinal cord lower down, of course. Got those extensions of their peripheral processes or axons into this area, established a relationship, a communication with the target cells, and just elongate it and move into the area of final functional establishment. So I don't want anyone to think that mesenchymal cells in these areas are differentiating into nerves. It's the nerve cells that grow with their target structures into these areas, and then the mesenchymal or endodermal origin tissues and cells develop in that area. Okay, we recognize the tongue and the ventralmost portion, excuse me, the inferior or ventralmost portion of this early nasal-oral cavity structure. It is still extending well into that area. Therefore, the lateral palatine processes cannot push above the tongue to meet in the midline, and the oral cavity is seen here. Here's the developing gum that we had talked about before. Then we recognize what looks like early bone formation here down in the mandible. And one other point on orientation, we should always remind ourselves to orient to the surface epithelium in this area of ectodermal origin. And underlying that is going to be some type of connective tissue holding that epithelial cell in place. And we have a mixture of mesenchymal cells and terminally differentiated cells and the range in between. So underlying the epithelial layers will be the mesodermal tissue. And remember, a lot of the mesenchyme in here has developed from neural crest cells. There's a little bit of mixing that goes on, but it's specialized mesenchyme cells because many of them, or most of them, differentiated from neural crest cells, the same neural crest cells that develop into these sensory nerves that send the process as to here to the vomeronasal nerve, or vomeronasal organ. Let's continue the views of the illustrations on this. So we're still proceeding to that same figure from the 6th to the 12th week. So we're getting toward the end where the 12th week will reveal the complete fusion of these lateral palatine processes. We orient to the brain, the olfactory nerves, and the olfactory epithelium. That's the roof of the nasal cavity. In the midline will be the nasal septum. We see the developing skeletal system, whether it's cartilaginous or ultimately becomes ossified. You know that there's a cartilaginous portion of the nasal septum and a bony portion of the nasal septum. There's also another bone that forms down here at the fusion with the hard palate, where the lateral palatine processes join this nasal septum. It's called the vomer. And we'll take a view of those a bit later, and possibly not within this lecture context. We see the nasal concha are becoming very pronounced, with spaces developing inferior and lateral to them, and the invading or establishment of the bone primordium, let's just refer to it that way, and the point of fusion of the two lateral palatine processes in the nasal septum, of course, represent the separation of the nasal from the oral cavity. So now the only space they share in common is the pharynx, and there's a separate nasal pharynx that opens into the oral pharynx. Then in panel H, again, consistent with the pattern so far, we're looking at an inferior view of the roof of the oral cavity. The hard palate is shown here with the soft palate and the uvula at its most posterior portion toward the back of the head. And the palatine raphe is illustrated here. And we know if we've ever looked at the roof of our mouth, actually the mucosa lining the roof of the oral cavity does have an indentation there where there isn't much loose connective tissue under the epithelium. There's just a more dense connective tissue fusing the epithelial layer directly to the hard palate, and that, of course, is right at the palatine raphe. Obviously, the front of the face at the margin of the oral cavity is completing its fusion at the midline, and we see the upper lip, the superior labum here, and we know that at the point where they fuse in the midline, there is a thin slip of mucosa that attaches that midline point of fusion to the adjacent structures, and this is called a frenulum. So there's a frenulum of the upper lip, a frenulum of the lower lip, and a frenulum of the tongue, as you know. Thus, we know that the lip has the connection, as we know on ourselves, to the surface epithelium at the vermilion border, as it's called. The vermilion means a dark red color, the color of our lips. So the border with the skin right at the margin is the vermilion border. So that would be right at the cut edge up there. So this would become the vermilion part of the lip, the colored part of the lip. Still covered with the same type of epithelium, just no hair follicles, right? Stratified squamous keratinizing epithelium, and the frenulum at that point. So when we follow that upper lip in, we know that there's the vestibule of the oral cavity, the space between our lips and the teeth and the gums. So that's that little depression in there. And then the elevated horseshoe-shaped area, obviously, is the developing maxilla with called the alveolar process without the teeth. So the portion that the teeth fit into is called the alveolar process. So we recognize really all of the mature structures, whether we're saying mature with reference to embryo and fetus or adult. We all know that most mature adults, senescent adults, end up right back at this level when all our teeth disappear. Continuing then with the overview or review of the secondary palate. The processes, the lateral palatine processes, fuse in that midline plane as we had seen, progressing from the 6th to the 12th weeks. And certainly the fusion of the nasal septum with those fusing or fused lateral palatine processes is in the latter part of that, the 9th to the 12th week. So the vertical nasal septum, as we saw, continued to grow inferiorly as these two lateral palatine processes grew toward the midline. They met more rostrally toward the front or anteriorly, and like a zipper closed off posteriorly toward the back of the hard palate. There is a critical window that occurs at the end of week 6 through the beginning of week 9. If these events don't occur during that time successfully, then there will be a persistent space between them. And it can range, obviously, through a wide variety of possibilities. And we'll take a look at some of those after we go through this. I'm going to just take the time to read this legend for you, and then we'll go through the coronal sections. So we're going to look at the human embryonic heads showing the palatine process. So we'll, again, see what we've been talking about. They're growing out in a shelf-like fashion, so they're also called the palatal shelf. It's during the 8th week, and in the panel A, the first one we'll look at, we're considering a crown rump length, or a CRL, of 24 millimeters. We'll see the early development of those palatine process. There's a scale on there, and we're not going to worry about those so much, except that we'll see that scale will grow longer and longer. Starts at 6, goes to 10, and then ultimately to 12 units. So this is what we had said. There's that elongation of the head in pretty much all directions. The embryo in panel B will be the CRL of 27 millimeters, so just 3 millimeters longer. And we'll see the palate just before it will elevate above the tongue and begin to move toward the nasal septum in that area. Panel C will be 2 millimeters later, CRL, about the end of the 8th week. And we'll see that the palatine processes are elevated and fused, so we assume that this is slightly more rostral toward the front, or anterior toward the front, and it'll have the longest scale. Thus, in panel A, we're looking at the 24 millimeter here, so you see it goes from 1 to 6. So this is these units of distance, whatever they might be. It can be arbitrary, doesn't matter, they're going to double from 6 to 12 over this range of time. Again, we recognize the nasal septum. Anybody remember what this is? Vomeronasal organ. So developing in that area. No real evidence of the nasal concha yet in the lateral walls. And we, of course, recognize the tongue, the oral cavity, and the lateral palatine processes. Surface epithelium lining all of these, thicker nasal mucosa up here toward the roof of the nasal cavity, and thinner at this level of section in most other areas. What will most of these cells develop into within the tongue? A lot of mesenchymal cells in there. What are they going to develop into? Inside the tongue. Skeletal muscle, right? So we're going to have a lot of skeletal muscle and a lot of connective tissue as well. And we've got the vasculature, and the nerves are already there. There'll be specialized development of the surface epithelial cells and some mesenchymal cells as supportive cells, and the nerve cells, the sensory nerve endings in this area to produce the taste buds ultimately. So in panel B, we went from 24 millimeter to the 27 millimeter. We're now at 10 units here, but the tongue is still occupying a large portion of this area, and the lateral palatine processes cannot extend dorsal to it just yet, but we recognize the vomeronasal organ in the nasal septum, and still the oral cavity here just on each side of the tongue. We orient to the surface epithelium, and we go deep to that, and we see that there is condensation of mesenchymal cells, so something is going on. This looks like a condensation that's just getting ready to begin lay down, or it's on its way to develop into a bony structure. So there's going to be bone, vasculature, connective tissue, nerves will already be in this area, and musculature that's going to develop from all these mesenchymal cells in this area. Move my pip here. How would you refer to this layer of cells on the surface that we see over here? Surface ectoderm, right? This is surface ectoderm on the outside of the developing face. Remember, still all the epithelium in here is from the ectodermal origin. Then we go to panel C, and we see that the nasal septum it looks like the oral cavity still occupies a lot of space, but everything is bigger. We are seeing less of the nasal cavity. We're just seeing the nasal septum beginning to join with and fuse with the two lateral palatine processes that now meet in the midline. We're beginning to see this radial array of connective tissue and mesenchymal cells that's characteristic of a cross-section of the tongue. and we're recognizing characteristic patterns of the distribution of the mesenchymal cells where we saw that condensation earlier. So a lot of activity going on out here, just tremendous to think of the communication between the cells and the coordinated effort to accomplish all this. Question, yes? The question is on this panel B, what actually is the lateral palatine process? And it begins here just at this little bulge and extends down to the side of the tongue and comes back up. It's due to the growth, the three-dimensional growth altogether of the head, right? So the top of the head is going to move away from the jaw, the bottom part of the mandible, going to stretch out that way as well as in every other direction. So ultimately, what they're showing is from the floor of the mucosal floor of the oral cavity down here to the inferior margin of the nasal septum, that we had started with 6 units of measurement, went to 10, and as well, you don't gain a lot of ground on that because everything's growing bigger as well. Like you said, the tongue even looks larger here as well. And we're assuming these are all at the same magnification, which is a safe assumption. And then ultimately to 12 units, and these 12 units represent just the oral cavity now, basically. So the development of the lower mandible and just the movement of everything in every direction has created the additional space for these palatine processes ultimately to flap up over above the tongue and continue growing toward the midline. And of course, we're at about the mid-level of the tongue, maybe. So we know that farther forward, anteriorly toward the front of the face, the oral cavity, the tip of the tongue is going to be smaller. So that's where the lateral palatine processes can come together first, get over that smaller part of the tongue, and then as the tongue gets out of the way, you just get the fusion like a zipper back toward the posterior end of this. So there can be failures within this critical window of time for things to develop. I'm certain that it's still very poorly understood. I'm sure there's a tremendous amount of investigation into this, but it's hard to find models of this other than in humans to investigate what really is going on cellularly and molecularly. And of course, most of these can be repaired surgically. So when there's a surgical approach to reparation in these situations, there's very little social concern and money to follow that to support tremendous research efforts to investigate this. Obviously, there'd have to be some type of marker that could be detected and some type of either invasive or non-invasive, such as a pharmaceutical agent, to attack, well, not really attack, but to begin to treat early on when the earliest signs of detection could be occurred, and it'd have to be in this critical window. Research that could go outside that critical window and have it fix itself is even more far-reaching than thinking of some marker maybe in the 6th week and would indicate that it's not going to fuse appropriately. If there was some way to get in, surgically get in there and do it. And they are doing fetal surgeries. We're probably far from doing this type of a procedure, but surgeons are amazing, as we know, and constantly investigating new approaches. Or if there was a pharmaceutical approach that would signal the cells so that they would do what they're supposed to do at the time. But mostly, as we know, it's after birth if the services are available, and a surgical approach would be used to repair this. Thus, one of the first ones we can discuss is the cleft lip. So there's all variations of this, as we had said, and it depends upon what occurs, and no one really knows exactly what are the causes leading up to any one particular variant. There are observations of how things proceed structurally, but not a tremendous amount is known otherwise. And I say that without having read much of the literature, so I'm not pretending to be a non-expert because I have read anything in that area. Just claiming ignorance. So the frequency of the cleft lip is 1 in 1,000 births. So that's somewhat frequent. That's I'd much rather see numbers in 1 in 10,000 or 5 in 100,000, something like that. So this is a recognizable, at least, if not significant, frequency. There's greater incidence in males by 60 to 80% within that group. There can be a unilateral cleft lip caused by failure of one maxillary prominence to fuse with the medial border of the nasal prominence. So similar to the formation of the palate, as we saw with the median palatine process and the lateral palatine processes, 3 processes coming together to fuse and close off this general opening in this area. There are 2 maxillary prominences on the surface pushing forward, and the medial median or midline located nasal prominence that comes in that area as well. So those 3 processes have to come together. So if you have 3 processes come together, you have 2 points of junction between the 2 lateral processes and the 1 midline where failure to fuse can occur. So if it's just on one side, it can be unilateral. If failure on both sides, bilateral cleft lip, so both of the prominences will not meet and fuse with that nasal prominence in the center. There's usually some type of genetic predisposition in these cases, so obviously there is some information known, and very likely someone has chased down the gene sequence, trying to predict a gene product sequence, and determine what might be going on there. Obviously then, if we're talking about the surface structures, the 2 maxillary processes and the midline nasal process or prominences, and then similarly, the palate, the median palatine process and the lateral palatine processes can be involved to one degree or another as well. And in pretty much all the different combinations, with or without involvement of the surface structures and to varying degrees of the palate. So the cleft palate occurs 1 in 2,500 births. So this is a little less frequent than the 1 in 1,000. And it's more common in females than in males. And it's caused by failure of the lateral palatine processes to fuse together, as we had indicated before. So we can almost predict that one of the more common cleft palates would be failure to fuse at the posterior-most portion of the palatine, lateral palatine processes. But the different variants do occur, as I said. And there seems to be a genetic predisposition to this as well. To view some examples of this, we'll be looking at figure 1044. Again, this is from the earlier edition of the textbook. So we'll look at the anomalies of the lip and the palate. First, at a complete unilateral cleft of the lip and alveolar process. So the alveolar process, as I mentioned, is the bony and mucosal covered area, more so just the bony portion within which we find the teeth. So it may not reach the palate, but it still can involve the maxilla where the teeth develop. And then in panel B, we'll look at the complete bilateral cleft lip and the alveolar process with the bilateral cleft of the anterior palate. And then in C and D, the bilateral cleft of the posterior or secondary palate, where the lip is normal because the maxillary prominences and the nasal prominence did fuse in the midline. What is the name of the structure superior to the upper lip in the midline, representing the point of fusion of the nasal prominence with the maxillary prominences? The angels told us to go shh. Did that and just forgot it. The philtrum, right? F-I-L-T-U-R-M. That little depression from the base of our tongue, our nose, down to the vermilion border of the upper lip. So it is the philtrum. Here then, in this view, we can see a rather extreme case of the failure of closure of the maxillary processes. So the maxillary bone didn't form, and it is only unilateral. So this would be the left, and this would be the right, as we can orient. The right maxillary prominence obviously fused with the nasal prominence to close off the nasal cavity to form the external nares, and proceeds down to the vermilion border, and we see a portion of the gum, the alveolar process on the right-hand side, and then of course it's completely absent and begins on the left side over here. So there's a complete opening into the left nasal passage. See the tongue in the floor of the mouth as well. And this is the bilateral. So we see the remnant, I'll use that term, of the maxillary process on the left side, and on the right side did not fuse with the nasal prominence on either side, so there's a bilateral cleft lip. As well, the maxilla did not develop on either side. There might be a bit of bone here in the middle. However, there was sufficient fusion, apparently, to close off each of the external nares. And we recognize the tongue, the alveolar process there, and the upper portions of the upper and the lower, complete lower lip. So here's a portion of the upper lip in the central part, still did develop on this structure. So obviously the skilled surgeons can repair this, as we know, even the bony portion, although they won't be able to, as I would understand it, induce the development of the teeth, as we see the first incisors on each side developing already in this individual here. So this is a view into the oral cavity, and we can recognize the alveolar process, certainly because we see the early teeth, the upper and the lower alveolar process. Here is the tongue on each side there, depressed, probably crying really hard, so it opens up the oral cavity completely. And here we see the free margin on each side of the lateral palatine processes that did not continue toward the midline to fuse, so we would predict that this would be whatever developed of the nasal septum, and just the continuity of the moist mucous membrane from in the entire nasal cavity that we're seeing here. So a view like this typically would show, the hard palate with that palatine raphe that we mentioned, where this mucosa lining it would be fused tightly to the underlying bone. So the hard palate is completely absent. This is a similar type of a case, but we can see that the median palatine process did fuse a little bit with the lateral palatine processes. Again, we're looking at through the oral cavity at the roof of the oral cavity. And this looks just like that illustration in about the 7th or 8th week, where the fusion would have started rostrally and moved like a zipper caudally, and we said that the lateral palatine processes kept growing posteriorly, where they would fuse with the developing palatine processes, and the soft palate would develop in the overlying mesenchyme, and we see the split uvula on each side in this case. We see the glistening nasal mucosa on what we would predict would be the nasal septum, to whatever degree it developed. And of course, there's the tongue and the teeth on the lower jaw. Well, I'll stop there since we're out of time. There are just 2 more slides of text, so I'm confident you can read those and understand that material easily. So I appreciate your time and attention, and extend my gratitude to those of you that have logged on and volunteered to help us with the Science and Engineering Fair at the end of March.